What's up everyone, it's Max again for the final video in this mini-series. Today I'm going to talk about some of the horses and zebras of EKGs and then review some ACLS. I modified this lecture from the University of New England Urgent Care Clinic in 2023. As always, remember, if you hear hooves, it's probably a horse. I have no financial disclosures for this video and I'm recording these purely for educational value. So let's get started. So some people may find this history amusing. I touched on the use of the string galvanometer in my first lecture, and in 1908 the first ECG was applied to diagnose a patient. On the right side from the image on Wikipedia, you can see the buckets of water the patient would have had to put their feet into. To review, Einthoven's triangle, including the augmented vectors, were created to assess the heart in two dimensions. The addition of the chest or precordial leads V1 to V6 allowed for a sweeping three-dimensional view of the heart. I'd like to direct your attention to the lower right of the screen. As we move from V1 to V6, we are changing the direction of our sum of vectors, from negative to positive from V1 to V6, with a perpendicular or isoelectric vector right around V4. This change is called normal or physiologic R-wave progression. Disruptions to this can indicate hypertrophy. I like to comment on this progression so I can sound smarter than I am. To show a normal 12-lead EKG, we can see here that number 1, the rate is regular. Number 2, there is an upright, round, and symmetrical P wave before every QRS complex that has the same PR interval every time. Number 3, we can see that the QRS complex is less than 3 little boxes, or less than 120 milliseconds. And finally, we can appreciate that there is no obvious elevation or depression at the isoelectric line, or the J point. If I were handed this EKG, I would think through these points and say, this is a normal sinus rhythm rate of 70 to 72 beats per minute with a normal axis, normal intervals, and physiologic R-wave progression, with no ST or T-wave abnormalities. Here's a review of our intervals and components of the cardiac cycle. These things include the P wave, the QRS complex, and the T wave. This slide, as a review from Rebel Reviews, illustrates the EKG association to the coronary arteries. Do you remember how to assess for a posterior MI? Assessing for a posterior MI can be evident with the depression seen in the septal and anterior leads. However, it can also be seen directly by placing 3 extra leads called V7 through V9 on the patient's posterior thorax. How about assessing for right ventricular involvement in an inferior MI, and why? Well, you can perform a right-sided EKG with the addition or use of a single electrode, typically with V4 being placed on the right side of the chest wall instead of the left. This will show ST elevation in the termed V4R if there is right ventricular involvement. Sure, great. Why is that important? Well, the right side of the heart receives blood from the venous system. The entry of this blood into the right atrium, for this case, is termed preload. The right ventricle's ability to contract and expel blood forward helps with the dynamics of, quote, pulling the blood into the heart to keep this process moving. Sort of like a negative pressure system, although not really. In a myocardial infarction involving the right ventricle becomes akinetic and does not move properly. Thus, you are losing your plumbing, and the condition is termed preload dependence, as this heart cannot facilitate right-sided venous return adequately. Okay, again, great, Max. What does that mean? Well, let's create a scenario. Let's say there's a 62-year-old male presenting to the emergency department for substernal, crushing, jaw and arm radiating 9 out of 10 chest pain. They are diaphoretic and pale. Their blood pressure is 110/70. You'd like to administer nitrates to reduce myocardial demand. However, you are concerned about a potential adverse effect that could be life-threatening. So, the major concern in this patient, with confirmation of a 12-lead EKG, is that they have an inferior wall MI that includes the right ventricle, and this is leading to right ventricular failure. So, what is the mechanism of action of nitrates? Nitrates are an exogenous supply of nitric oxide through nitrate, which activates guanylyl cyclase and increases cyclic GMP. This decreases preload by peripheral venodilation, Reducing the preload too much or too quickly can theoretically be fatal in these patients. So proceed with caution. Moving on to electrolyte abnormalities. I'll just be covering 3 of the big ones you can see on EKGs. As a review, the cardiac conduction has 5 phases, 0 through 4, starting with rapid sodium entry and depolarization. The plateau phase, or phase 2, of potassium. The plateau phase is balanced by calcium entry. Thus, potassium greatly affects the repolarization of cardiac tissue. This will come into play in the next slide. As you can see in hypokalemia, or low serum potassium levels, there can be downsloping ST depression, with the presence of something called a U wave, which can be seen after the T waves. Flattening of the T wave, or its biphasic nature, can be thought of as a finger pushing down on the repolarization phase. The opposite can be said about hyperkalemia, where the finger is pulling the T wave up and spreading apart the QRS and PR interval. These are the stereotypical peaked T waves seen in hyperkalemia. I cannot urge everyone out there enough to visit Life in the Fast Lane's website for all your EKG needs. I always have this image in mind when thinking of potassium's effect on the EKG, both in low states and in high states. The next electrolyte abnormality is with calcium. Calcium helps create the plateau phase, as well as the initial depolarization to some extent, although that is dominated by sodium. Calcium is also important in stabilizing the cardiac membrane's sodium channels. Therefore, in low calcium levels, there is an increase in neuromuscular excitability with muscle cramping. In hypercalcemia, there is reduced neuromuscular excitability with muscle weakness. So, with hypercalcemia, the main abnormality we see is shortening of the QT interval. In severe hypercalcemia, we can see something called Osborn waves, or J waves, but we'll talk more about this later. We can also have ventricular irritability and cardiac arrest with extreme hypercalcemia. On the other hand, in hypocalcemia, the main abnormality is QT prolongation. Dysrhythmias are uncommon, although AFib has been reported. The main arrhythmia with QT prolongation that we worry about is something called torsades de pointe, which may occur, but its main association is with magnesium, which we will talk about next. The final electrolyte I'll talk about is magnesium, and I'm going to talk about it in reference to something called torsades. Torsades is a type of polymorphic ventricular tachycardia. This is a form of ventricular tachycardia in which there are multiple ventricular foci that result in QRS complexes that have varying amplitude, axis, and duration. Torsades is a specific type of this polymorphic ventricular tachycardia, and it has characteristic morphology in which the QRS complexes twist around the isoelectric line, or they twist around the points, hence the name. Now I'm talking about this in terms of magnesium and the electrolyte abnormalities, so the treatment for this is giving magnesium. And so we see the treatment of torsades, and hopefully before it degrades into ventricular fibrillation, is intravenous magnesium. From the National Institutes of Health, the recommended initial dose of magnesium is a slow 2-gram IV push, an infusion of 1 gram to 4 grams per hour. The importance of the magnesium is to ensure that the QT interval is not prolonged, as well as stabilizing the cardiac membrane, although the exact mechanism is unknown. Now let's continue our discussion on conduction systems and blocks. So the normal cardiac conduction system starts at the SA node and moves to the AV node and then down the interventricular bundle, or the bundle of His, into the right bundle and the left bundle branch. The left bundle branch also has 2 of its own that are called fascicles, but more on those later. So as with arteries and veins, we can have a blockage of the conduction system. These are termed bundle branch blocks. In a right bundle branch block, the left bundle branch has to take over for the right side, and then move from cardiomyocyte to cardiomyocyte to cardiomyocyte. And remember, these are the back roads, And when we move on our back roads, this takes more time, and thus the duration is longer than 120 milliseconds for the ventricles to depolarize. So because the right bundle branch is not working, the vector from the left bundle branch causes the R' waveform seen in V1, as there is depolarization going towards it. The opposite happens in V6, where there is this slurring of the S wave as a negative deflection. The exact opposite occurs in a left bundle branch with different terminology, RS and this R wave. For simplicity's sake, I'm going to teach you a trick that I learned from the visual nurse, Tyler, on Instagram. Definitely give him a follow. If you ever see an EKG with a wide QRS and a normal rate, you should be thinking about a bundle branch block. This is because the conduction system is delayed. Now I want you to think about driving a car. If you want to take a right turn, you move your turn signal upwards to turn on your right indicator, unless you're from the city. Therefore, in a right bundle branch block, our terminal wave is up or positive in V1. If you want to take a left turn, you smack your turn signal downwards, for our terminal wave in V1 is down or negative in a left bundle branch block. I hope this makes understanding these a little bit easier. So in the setting of a wide QRS complex, the repolar or from a paced rhythm, Scarbosa's criteria is used. There is a new modified Scarbosa's criteria of QRS complex, or concordant ST depression greater than 1 mm in V1 to V3, or if there is ST elevation that is at least 1 mm and has an amplitude at least a quarter of the preceding S wave, then this is diagnostic criteria for an ST elevation MI, or a STEMI. Any of these criteria are a positive finding. The third criteria point was modified to be more specific and sensitive. Concordance refers to the change at the J point in the direction of the terminal waveform. So in this first example, we have ST elevation in the direction of the terminal wave. So this is concordant ST elevation. In this example, we have concordant ST depression. In this final example here, we have discordant ST elevation. The third criteria used to say greater than 5 millimeters. However, they found that the preceding S wave being at least a quarter of the size at the ST elevation was sensitive enough for ST elevation MI. So, Scarbosa's criteria is used to determine if there's anything that's mimicking a STEMI. Well, another case of a STEMI mimicker is something called left ventricular hypertrophy. There are many ways to calculate if there is left ventricular hypertrophy, but the two data points that I use and what I was taught is seeing if the R wave in V5 or V6 plus the S wave in V1 are greater than 35 millimeters, as well as if the R wave in AVL is greater than 11 millimeters. So if there is ST elevation present and left ventricular hypertrophy, you can use something called Armstrong's criteria. Armstrong's criteria states that if there is ST elevation in V1 to V3, then you need to evaluate if these ST elevations or the RS wave ratio is greater than a quarter. This is very similar to the new modified Scarbosa's criteria. If this is not true, then it is not a STEMI. If this is true, we need to see if there are more or equal to 3 leads with ST elevation. If there is, we go right to a true STEMI, even in the presence of left ventricular hypertrophy. So going back to our original EKG from the other slide, we see that there is ST elevation in V1, 2, and 3, but the RS ratio is not greater than a quarter of the size of the ST elevation. Therefore, this is most likely not a STEMI, consistent with acute coronary syndrome. However, given an acutely presenting patient, it is better to be safe and overcall this as an ST elevation MI than to miss it. And this is per EMDoc's website. Alright, moving on to talk about some more conduction abnormalities. Let's remind ourselves that we have the SA node, the AV node, with a pause for filling at the PR interval, the bundle of His or the interventricular bundle, and the right and left bundle branches. And like I mentioned, the left bundle branch has 2 branches of its own called the fascicles, an anterior fascicle and a posterior fascicle. the anterior fascicle stays more on the midline of the heart at the septum and moves, well, anteriorly, while the posterior fascicle moves slightly laterally and, you guessed it, posteriorly. So, as we've all seen so far in medicine, if there's a physiologic structure, it probably can have disease. Just like the larger bundle branch blocks, the fascicles can have blocks as well. This can be an early sign of conduction system disease. As I mentioned, the anterior fascicle stays more on the midline and is anterior. If it is blocked, the posterior fascicle has to take over. When the posterior fascicle takes over, its vector force is directed laterally towards lead 1 and AVL. When this vector moves towards AVL and lead 1, there is a positive deflection seen on the 12 lead. The opposite happens at lead 2, 3, and AVF, where there is a negative deflection because the vector is moving away. The final piece of criteria is that there is an associated left axis deviation. This can be seen with lead 1 and AVF in opposite directions of each other. Remember your thumbs trick. If your left hand is lead 1 and your right hand is AVF, your right thumb goes down, so your thumbs have left each other, and this means you have a left axis deviation. These are the criteria for an anterior fascicular block. Notice how the QRS complex is not yet wider than 120 milliseconds, as there is not significant enough of disease to delay the ventricular depolarization more than that. Next, we have a posterior fascicular block. In a posterior fascicular block, the anterior fascicle has to take over, and this is the exact opposite of the anterior fascicular block, where the anterior fascicle's vector force is directed downwards towards lead 2, 3, and AVF, and away from lead 1 and AVL. So 1 and AVL will now be negative, while 2, 3, and AVF are positive waveforms. And again, notice that the QRS complex duration is still less than 120 milliseconds. Just like in an anterior fascicular block, there is an associated axis deviation, but this time it's a right axis deviation. And remember, our left hand is lead 1, our right hand is AVF. Lead 1 is negative. Now our thumbs are right for each other, so we have a right axis deviation. And just when you thought it couldn't get any more fun, we can have conduction disease in the right bundle branch as well as in the fascicles. This is something called a bifascicular block. In both bifascicular blocks, we have a right bundle branch block and a left anterior or a left posterior fascicular block with the associated axis deviation. Here are some examples of these bifascicular blocks. So this is a bifascicular block, again with our right bundle branch block. Remember, we want to turn right, so we smack our turn signal up. We can also see that slurring in V6 of the S wave. And we can see that we have a positive deflection in 1 and our next bifascicular block with the right bundle branch block again, but with a left posterior fascicular block this time. We have a negative deflection in 1 and AVL and positive deflections in 2, 3, and AVF, with the associated right axis deviation. The next topic I want to talk about is something called OMI patterns. We've been discussing a whole lot about STEMIs, but there are also myocardial injury that is not completely a STEMI, which we call an NSTEMI, or non-ST elevation MI. In the case of a STEMI, the damage done to the myocardium is termed transmural, meaning it includes the entire width of the myocardial tissue. In an NSTEMI, the damage is subendocardial, or only partially damaging. These two classifications do a good job at separating the damage of transmural versus just subendocardial. However, they are not perfect. Thus, the creation of the OMI patterns. These patterns are continually being identified to ensure that we are not missing transmural damage that doesn't meet qualifications as a STEMI, and it is an area of growing research. The first pattern I want to talk about is called the Aslanger pattern, which was identified in 2020. The criteria for this pattern are inferior ST elevation isolated at lead 3 and lead 3 only. There's also concomitant, or at the same time, ST depression in any of V4 to V6 with a positive or terminally positive T wave, and that the ST segment in V1 is higher than in V2. So if we come to our first example here, we see that in lead 3 there is ST elevation. And if we go to V4 to V6, we see that there is ST depression, some upsloping ST depression in V5 and V6. And then if we come to V1 and V2, we see that the ST segment is slightly higher than the isoelectric baseline of V2. So this pattern was observed in 6.3% of NSTEMI patients. And remember, NSTEMIs are subendocardial damage and not transmural. But this pattern was found to be a predictor of larger infarct size and higher mortality. And for all you SpongeBob fans out there, I put this in. In our second example, we can see that we have that ST elevation in lead 3. We can also see that the ST segment is higher in V1 than it is in V2. And then we can see in any of V4 to V6, we have ST depression in V4 and in V5. The next pattern I'm going to talk about is called De Winter T waves. De Winter T waves are a pattern synonymous to ST elevation MI, but without the presence of ST elevation. As you can see, there's T waves. This pattern is present in about 2% of acute LAD, or left anterior descending artery, occlusions. And in some cases, this was present before the ST elevation morphology became noticeable. The next pattern is called Wellens syndrome. Wellens syndrome is when there is biphasic or deeply inverted T waves in V2 and V3. And this Wellens syndrome is a clinical finding that, with recent and resolved chest pain, is highly specific for critical stenosis of the LAD. Now, there are two patterns of Wellens. There's a type A and a type B. The type A pattern is where there's biphasic T waves that you see here. That resembles another thing that we're going to look at later, as well as type B being deeply inverted T waves. Typically, this pattern is seen in the pain-free state, or without angina, and it may be obscured during episodes of ischemic chest pain when there is, quote, pseudo-normalization of the T waves in V2 or V3. Wellens syndrome is a key example of why all patients presenting with chest pain must have serial EKGs. The next topic I want to discuss is hereditary or congenital patterns. We're going to talk about Brugada syndrome, long QT syndrome, Bungard syndrome, and WPW, or Wolff-Parkinson-White. The first hereditary syndrome I want to talk about is called Brugada. In most people with Brugada syndrome, there is no genetic cause, and it is a somatic mutation. However, in some individuals, there is an autosomal dominant mutation in the SCN5A gene that causes the disease. This syndrome predisposes patients to having sudden cardiac arrhythmias and death. Brugada syndrome has a specific pattern usually seen in V1 or V2 shown on the screen. There are two types. One with downsloping ST segment after the ST elevation, the other with a saddleback type ST T-wave configuration. This positive waveform can sometimes take on the appearance of a right bundle branch block in type 1, but it is not truly that. I added some other facts about Brugada from Life in the Fast Lane at the bottom of the screen. The next condition I want to talk about is something called long QT syndrome, or Jervell-Lange-Nielsen syndrome, autosomal recessive long QT syndrome, or cardio-auditory syndrome. And the reason it was called cardio-auditory syndrome is because this was associated with severe bilateral sensorineural hearing loss. There are two genetic mutations identified encoding cardiac potassium channels for this disease. And remember, the potassium channels are part of our repolarization phase, hence why this QT interval is prolonged. And due to the high risk of sudden cardiac death, an implantable cardioverter defibrillator is usually required. In my research preparing for this presentation, I found this article from the Proceedings of Pediatric Societies from 1953, and it was called The Case of Cardiac Syncope. I thought the patient descriptors and physical examination documentation was interesting. It is truly amazing how far we've come from 1953. The next very rare condition is called Bungard syndrome, or familial ST segment depression syndrome. And by its name, I think you can guess that there is ST depression. So, in part A here, we have concave upward ST segment depression in leads 1, 2, AVL, AVF, and V2 to V6. We also have ST segment elevation in lead AVR, plus or minus V1. And that there is a notch visible in the ascending part of the ST segment in the precordial leads, most prominent in leads V3 and V4. And the idea in this condition is that persistence of this pattern without symptomatology is important for the diagnosis. And we'll talk about that in the next slide with the importance of ST elevation and AVR. And I know we've left AVR out of the equation for a while, but we're going to come back to them. So, diagnosing familial ST segment depression syndrome, we need unexplained concave upward ST depression in at least 7 leads, ST elevation in lead AVR, and these ECG findings are persistent with time, and it seems to be that there's an autosomal dominant pattern of inheritance for Bungard syndrome. So to not leave you hanging on AVR, this is our side note, the neglected lead. Lead AVR is previously assumed to carry little diagnostic value, as its vector is directed away from left ventricular depolarization, everything that we've talked about so far. But ST elevation greater than 1 mm in lead AVR has been shown to be 80% sensitive and 93% specific for left main coronary artery, or proximal left disease, or triple vessel disease in patients with non-ST elevation acute coronary syndrome. So as they say in Life in the Fast Lane, we should be replacing the STEMI misnomer with this OMI pattern, as we see ST elevation in AVR, and we see ST depression kind of globally. Another side note on top of my side note, let's keep this pattern in mind for later, as we see ST elevation in the depression globally. The exact opposite can be seen in a different disease. The next syndrome is something called Wolff-Parkinson-White. In Wolff-Parkinson-White, there is an accessory pathway that is outside of the normal conduction system. Because of this aberrancy, we can have something called pre-excitation, where we have excitation of the conduction system outside of what is normal. The hallmark findings on EKG of this syndrome are a short PR interval, less than 120 milliseconds, the presence of a delta wave, which is a slurring, slow rise of the initial portion of the QRS, and also something called pseudo-infarction pattern in up to 70% of patients, where we have these pseudo-Q waves. Now, this accessory pathway can be left-sided or it can be right-sided in either a type A or a type B pattern. Now, this accessory pathway can be through something called the bundle of Kent, which is the reentrant cycle through from the ventricles to the atria again. This inappropriate pathway can cause something called an atrioventricular reentry tachycardia, i.e. its reentrance to the atria from the ventricles. Now, a brief side note on atrioventricular tachycardias. We have pre-excitation, where we have this shortened PR interval and this slurred upstroke into the QRS called the delta wave, where we can't see the PR segment. We then can have something called orthodromic AVRT, where there's antegrade conduction through the atrioventricular node, meaning through the AV node down the ventricles and back up again through the AV node. In this type of AVRT, we can see that there is a retrograde, meaning past the QRS, and inverted P wave, as well as a normal QRS duration, and of course, because there's no pre-excitation pathway, there's no delta wave. The other pattern we see is antidromic AVRT, where there's retrograde conduction through the AV node. In this type of AVRT, there is, again, retrograde conduction past the AV node and through the ventricles. In this type of AVRT, there is a wide QRS complex with a delta wave. You rarely can see a P wave, like you could see a retrograde P wave here with orthodromic AVRT. In this slide, I have an example of the Wolff-Parkinson-White pattern. Specifically, this is a type A pattern. But first, we can see the P wave with a slurred upstroke of the delta wave with a wide QRS complex. We can also see some tall, prominent R waves in the precordial leads that kind of mimic right ventricular hypertrophy. So why is it important to be able to identify this short PR interval, the delta wave, with the slurred upstroke? Well, the reentrant tachycardia is not being conducted through the AV node as it should. The AV node is actually the savior for these patients as a failsafe. If someone with Wolff-Parkinson-White is in this atrioventricular reentrant tachycardia, and you use a medication that blocks nodal tissue, like at the AV node, such as your class 2 or class 4 medications, such as a non-dihydropyridine calcium channel blocker or beta blocker, the transient block to the AV node can actually precipitate a fatal arrhythmia. The next topic I want to discuss is metabolic derangement and other findings on EKGs. So the first metabolic derangement we will talk about is a TCA overdose or a sodium channel blocker overdose, as they present in a similar fashion. So who are the TCAs? These are the things like clomipramine, doxepin, which is one that people forget about, amitriptyline, and nortriptyline. So the key findings are these 3 C's, but there's a fourth one I added in. So the 3 C's are convulsions, coma, and cardiotoxicity. I also added an anticholinergic as well, because that's one that's often associated with these TCAs. And here's the EKG finding. We have a wide QRS, tachycardia, and this terminal R wave in AVR. So besides anticholinergic and sodium channel blockade, the TCAs can also have numerous other effects on the body. These are important pharmacological effects to know when treating TCA overdoses. So, how do you treat it? So in severe TCA overdose, this is more of a side note from EKGs, but an overdose greater than 10 mg per kilogram with signs of cardiotoxicity, this requires resuscitative management. So you'd secure IV access and you would administer IV sodium bicarbonate. You can also intubate and hyperventilate for a pH of 7.5 to 7.55 and also give activated charcoal through an NG tube. If there are seizures, you can treat with IV benzodiazepines. If there's hypotension, with crystalloid bolus. And if arrhythmias occur, the first step is to give more sodium bicarb. Lidocaine can be used in a third-line agent after bicarbonate and hyperventilation, once the pH is greater than 7.5. This is protective against the arrhythmias in a TCA overdose. And remember to avoid class 1A and C antiarrhythmics, as well as beta blockers and amiodarone, as they may worsen the hypotension and conduction abnormalities altogether. And of course, you would admit the patient to the intensive care unit for ongoing management. So to continue with sodium channel blocker overdose, i.e. our TCAs we talked about, delay, that terminal R wave. We can also see patients with TCA overdose will usually cause sodium channel blockade, or things like, well, the TCAs we talked about, that's the most common. You can also get some of your antiarrhythmics that can cause it, or 1As and Cs. And local anesthetics that do move systemically, antimalarials, and others. Alright, this next pattern is more of a vascular event than it is a metabolic one. But what do we see here on this 12 lead? Well, we have a P wave for every QRS, we have a narrow QRS complex, and we have a T wave in an appropriate QT interval. So we could say this is a normal sinus rhythm. But let's come over to the precordial leads, and we're kind of missing the obvious here. So there are these deep inverted T waves. These deep inverted T waves could be a sign of ischemia or something like a Wellens pattern, but let's say I paint you a picture of a patient. So let's say that there's a patient who's in the emergency department, they're intubated, they're obtunded, and they're showing signs of a stroke. So this is something called cerebral T waves, and they're particularly common following a left frontal hemorrhage. You see deep inverted T waves in the precordial leads, and it's associated with increased intracerebral pressure. The next EKG finding is something called the Ashman phenomenon. So this is typically seen with atrial fibrillation or other supraventricular tachyarrhythmias. In this case, we have an atrial fibrillation. And the Ashman phenomenon is usually in a right bundle branch morphology, i.e. these bunny ears, or our right turn signal. And it's clinically benign and requires no specific treatment. So what's actually happening in this phenomenon is where we have a period of a long R-to-R interval and a short R-to-R interval to where we have an aberrant beat, or an extrasystole, or a PVC. So the Ashman phenomenon describes an aberrant ventricular conduction, usually of right bundle branch morphology, which follows a short R-to-R interval, and preceding relatively long prolonged R-to-R interval. So the next topic I want to discuss is something called J-point elevation and notching. We've talked about J-point elevation in the setting of an ST elevation MI, but we can also have J-point elevation in something called pericarditis, benign early repolarization, and something called the Osborn wave, or J-wave, that we mentioned earlier. So in pericarditis, there is inflammation of the pericardium, and there are many causes. The classifications can be primary or secondary, acute or chronic, infectious or immune-mediated. Some of the infectious are mainly viral, things like Coxsackie virus. Immunologic can be lupus. Remember, lupus is always on the differential, and rheumatic fever. You can also have uremic pericarditis from renal failure. And we can have something called a postmyocardial infarction or following cardiac surgery, and this is called Dressler's syndrome. You can also have trauma, paraneoplastic syndromes, drug-induced like isoniazid and cyclosporin, post-radiation therapy pericarditis. So what are the EKG changes seen in pericarditis? Well, this is similar to that pattern I told you to keep in mind from earlier, where you have widespread concave ST elevation and PR depression throughout most of the limb leads. You have reciprocal ST depression and PR elevation in AVR, plus or minus V1. And you can also have sinus tachycardia, as this is very common in acute pericarditis due to either the pain or an effusive process. So, in V5, we have PR depression and ST elevation. And in AVR, we have PR elevation and ST depression. This is the exact opposite pattern to what we saw in an AVR elevation, which was our neglected lead that could be associated with a left main coronary artery or triple vessel disease. So I wanted to put a slide in on Dressler syndrome just because I mentioned it. And you can see on this MRI of the heart, you can see the inflammation of the pericardium, how the uptake is different. So Dressler syndrome is a fibrinous or fibrinohemorrhagic secondary pericarditis that occurs as a result of injury to the heart or pericardium, either from an MI or cardiac surgery. And the exact cause is unknown, but it appears to be immune-mediated. The next J-point elevation syndrome is something called benign early repolarization, and this is less of a syndrome and more of a benign finding seen in a lot of young athletes or young people. So the ECG of benign early repolarization is generalized concave ST elevation in the precordial leads and limb leads. So you can see this ST elevation. And one of the funny things that you can think about is that this concave versus convex. The concave is kind of like a smiley face, so it's smiley uppies versus frowny downies. So this J-point notching is evident in the inferior leads, as I'm pointing out here. But the important thing to note is that the ST elevation to the T wave ratio is less than a quarter in V6. So in comparison, pericarditis versus benign early repolarization, we can measure the ST elevation versus the T wave height in V6. So the vertical height of the ST segment elevation at the J point is measured. So the ST-T wave ratio greater than 0.25 or a quarter suggests pericarditis. Less than a quarter suggests benign early repolarization. Obviously, you would have signs and symptoms of pericarditis, and this is benign, so you wouldn't have any symptoms. So in V6 here, we have the measured ST elevation at 1 millimeter, the T wave height at 6 millimeters, so the ST-T wave is 0.16. And over here we have 2 millimeters and a 4 millimeter height T wave. The ST-T wave ratio is 0.5. The next J-point abnormality is something called the Osborn wave. So the Osborn wave, or J wave, is a positive deflection seen at the J point in the precordial and limb leads. So you can see this extra bump here at where the J point is. It is most commonly associated with hypothermia, although you can see it in hypercalcemia like I mentioned earlier. But its most common association is hypothermia. And compared to other hypothermia-induced EKG abnormalities, like bradycardia, SVT, QT prolongation, or AV block, the Osborn wave is thought to be the most specific. So over the next two slides, I give you examples of temperatures of patients and what their EKG looks like. So in this one, we have mild hypothermia at 90.5 degrees Fahrenheit with the evidence of a J wave. In this slide, we can see that there we have J waves and elevation. And this is moderate hypothermia at 86 degrees. Again, we see worsening J waves with elevation here, and this is moderate hypothermia again at 82.4 degrees. And finally, we can see severe J-point elevation, and in the inferior leads, this is severe hypothermia. This patient was 78.8 degrees. All right, so what's the rhythm? Is this EKG here ventricular tachycardia? Or is it a supraventricular tachycardia with a right bundle branch block? It's hard to tell because it is a wide QRS, it is regular, and it's very fast. So one of the ways you can tell the difference between a VTAC and an SVT with aberrancy is something called the Lewis lead. The Lewis lead is rearranging the four-lead system, and this helps accentuates atrial activity. So if there's P-wave dissociation when you look at lead 1, then you're in a ventricular reentry, aka it's VTAC. As you can see here, these P waves are not lining up with the QRS complexes like they should. They're beating on their own. One of the quicker ways that you can differentiate is actually changing the filter speed on the paper. It's usually set around 25 millimeters per second, and you can change that and help see some of these P waves if they're there. And for my final slide on EKGs before I talk about some ACLS, I'm calling it high yield patterns, and it's from Life in the Fast Lane. I put the link to killer ECG patterns, and they had this piece of information saying the average emergency clinician performs around 100 tasks per hour and gets interrupted every 6 minutes. I just thought that was an interesting perspective. So in this final part of the PowerPoint, I'm going to do a brief look at ACLS, talk about the algorithm, CPR, what to do and how to do it, talk about some of the medications, and then I have a little quiz. To finish up our PowerPoint here, I'm going to talk about the adult cardiac arrest algorithm. So let's say you're going to see a patient and you notice that they don't have a pulse and they're not breathing. Oh no! Let's think about our algorithm. The first thing you should do is start CPR. You should give them oxygen, attach a monitor and a defibrillator, and call for help. Doing CPR, the quality is very important. You should push hard and fast, which is at least 2 inches, and fast at 100 to 120 per minute. Well, how fast is that really? Well, I've put together a collection of CPR songs that I can share with you in the link below. So the next step is to determine what the rhythm is. Do we shock them or do we continue CPR and give medication? Well, we have 4 arrest rhythms. 2 of them are shockable, 2 of them are not. The 2 shockable rhythms are VFib and pulseless VTAC. The non-shockable rhythms are asystole and PEA, or pulseless electrical activity. So let's say we Identify a shockable rhythm. What do we do next? VFib or pulses V-tach. We shock them, and then we continue CPR immediately. We reassess if the rhythm is shockable. If it is shockable, you shock them and continue CPR. This is when you can use epinephrine every 3 to 5 minutes. You can get an advanced airway and use capnography. And again, after this 2 minutes of CPR, what do? We reestablish. Is it shockable? If it is, shock it. Then continue CPR immediately. And then you can move towards your antiarrhythmics like amiodarone or lidocaine, and then treat reversible causes. We'll talk about the reversible causes in a minute. How about we say that the rhythm is not shockable? It's asystole or pulseless electrical activity. Well, this is where we would give epinephrine ASAP, and we'd continue CPR. We would get IVIO access, epinephrine, advanced airway and capnography, and then we would see if the rhythm is shockable. If it's not shockable, we stay on this path and we continue CPR. And this is where we get to our reversible causes. So the reversible causes are things in cardiac arrest while we're using this algorithm to think about and to perform and do to hopefully reverse the cardiac arrest. And these are things like the reversible causes, H's and T's, hypovolemia, hypoxia, hydrogen ion, and others, including the T's, tamponade, tension, thromboembolism, trauma. All of these things we can reverse while using the algorithm to hopefully save the patient. So, my first question, what 2 electrical rhythms do you use defibrillation? That would be VFib and pulseless V-tach. PEA is not a shockable rhythm. VFib is. Atrial tachycardia is not an arrestable rhythm. V-tach is not an arrestable rhythm unless it's pulseless. Asystole is not a shockable rhythm. Next question. The following are reversible causes, H's and T's, of cardiac arrest except we have hypoxia, toxins, tamponade, tummy upset, tension pneumothorax, or hydrogen ion. And obviously the answer is hypoxia. No, I'm just kidding. Our next question is, after providing a shock with an AED, you should start CPR, beginning with chest compressions, check a pulse, give a rescue breath, let the AED reanalyze the rhythm. And our answer is start CPR. After you shock someone, you continue CPR. And after that brief overview of the ACLS algorithm, I'll leave you with this arrhythmia practice from the 4th lecture on the 6-second ECG by Skillstat. It's a great website and it's free. Alright, so that's all I have in this EKG mini-series. I know these videos were packed with material. This one specifically was loaded with zebras, and some of the videos may have gotten edited a bit better than the others. But I hope you found all this information useful and have a better grasp on EKG interpretation. Thank you so much for listening.